ocular, medical, medication, social, and family history and documentation. History is the patient's version of the medical problem. Ask questions about the patient's symptoms. Specific questions elicit more detail, which helps the physician make a diagnosis. An ophthalmic history should include the following: a chief complaint, history of present illness in the patient's own words, history of past health, significant medical illness, previous eye disease, previous surgery, eye and general, medications, allergies, inhalants. Family history, ocular, would include myopia, strabismus, glaucoma, blindness, and diabetes, and in the patient's social history, occupation, type of work, and industrial hazards. The chief complaint should be short and a concise description of the patient's problem. It should be the patient's main concern, why they're there for the exam. Some examples could include experiencing pain, loss of vision, difficulties with reading. This should be recorded in the patient's own words. The history of present illness gives a greater detail of the chief complaint. Further questions are used during the history of present illness to pinpoint which eye, the duration, extent, and onset of the patient's complaint. And you can use specific questions based on the complaint. And be sure to know the difference between signs versus symptoms. So looking at the example, chief complaint, difficulties with reading, the history of present illness would then further pinpoint that it happens in both eyes, it's worse at night, in poor lighting, started 5 to 6 months ago, and it is getting worse. Past health, be sure to include non-ocular medications, hospitalizations, trauma, and surgery, a patient's allergies, and the true allergy to a medication. Hives or difficulty breathing would be an example of a true allergy. Other reactions are considered sensitivities. Also ask about drugs, inhalants, contactants, ingestants, and injectants. Looking at our example for past health allergies, patient could have a history of thyroid illness and they're allergic to penicillin. You should include in the patient's medications their ocular and systemic medications. Be sure to always record the dosage, strength, the time the patient last took the medications, and if they're compliant. Do they actually take the medicine? And is the medication prescribed or is it over the counter? Here are the social aspects of the history and documentation. Occupation, type of work, industrial hazards. Does the patient smoke, drink alcohol? What are their hobbies? And have they experienced any weight loss or gain? So our patient social history here, as an example, they're a carpenter and a non-smoker. The family history would include ocular and systemic, migraine, retinitis pigmentosa, color blindness, nystagmus, albinism, sickle cell anemia, choroideremia, keratoconus, Marfan syndrome, and diabetes. In this family history example, our patient's maternal grandmother had diabetes. Let's move on to the next portion of the CO exam, which is worth 6%, visual assessment. You'll be expected to test and record visual acuity appropriately for patients with all levels of acuity. Test and record visual acuity on pre-literate, illiterate, nonverbal, low vision, or foreign language patients. Define low vision. Test and record visual acuity using the pinhole occluder. Test and record stereo acuity. Test and record near point of accommodation and convergence. Test for visual acuity, distance and near, using optotype, Allen, tumbling E, numbers, and Snellen. Describe the advantages and disadvantages of different low vision devices. So let's take a look at test and record visual acuity appropriately for patients with all levels of acuity. Visual acuity is determined by the smallest object that can be clearly seen at a specific distance. 20 feet or 6 meters is the accepted distance used for distance visual acuity. Optotype size can be adjusted for shorter or longer distances between the patient and the chart. Snellen charts are designed so that each letter subtends an angle of 5 minutes of arc. Test and record visual acuity appropriately for patients with all levels of acuity. Patient covers one eye and reads the eye chart as far as they can see. You would encourage the patient to guess. So it's okay to push them a little bit to see if they can read a little bit better than the line they just read. You would then record the lowest line the patient was able to read. Record plus letter or minus letters as appropriate. The numerator is the patient's testing distance. The denominator is the distance at which the optotype subtends an angle of 5 minutes or arc, or the distance at which a normal person can see that particular optotype. For the patient who cannot read the largest letter, you would decrease the distance between the patient and the chart and then record appropriately. You could then ask the patient to count fingers, indicating the distance the patient was able to count fingers. From there, if the patient is unable to count fingers, you would then do hand motions. If unable to see hand motions, light perception with projection. From there, light perception without projection, And finally, no light perception. For patients who cannot read the letters, there are other options. You could show them numbers, pictures, Landolt's broken ring, or tumbling E, which is the example pictured here. Low vision is defined as corrected central vision less than 20/40 in the better eye, or visual field loss, or contrast sensitivity loss. A pinhole disc with a single hole or multiple holes can be used in testing and recording visual acuity. The pinhole helps to eliminate peripheral rays of light and improves contrast. It essentially eliminates decreased vision due to refractive error and differentiates vision loss from a refractive error in a disease of the eye. So here are some examples that could happen when you use a pinhole occluder. If the patient's vision increases while using the pinhole, it could equal a refractive error. If the patient's vision does not increase with the pinhole, it could point to some type of eye disease. If the pinhole the vision decreases with the pinhole, then we could be looking at a potential macular problem. Test and record stereoacuity. So stereoacuity equals stereopsis, which equals depth perception. This is a visual blending of two similar images, not identical, one falling on each retina into one with visual perception of solidity and depth. Based on the coordinate use of both eyes together, for a patient to be able to have stereoacuity or depth perception, they need good vision in both eyes, overlapping visual fields, and normal alignment of the eyes in all positions. Continuing with test and record stereoacuity. Let's take a look at the fly test. This tests gross stereopsis, or 3,600 seconds of arc, when tested at a 40 centimeter distance. The word stereo test are the three lines of animals, suggesting around 100 seconds of arc if all are identified. The 9 frames of raised rings indicate the patient can see around 40 seconds of arc if all 9 rings are correctly identified. Next, near visual acuity. Near visual acuity is assessed at 14 to 16 inches and is recorded as the smallest line that the patient can read. There are various near testing cards available. Notation systems for near visual acuity include a Snellen equivalent, Jaeger system, and the printer's point system. Testing for visual acuity using optotypes. Let's take a look at what an optotype is. Any letter, number, picture, or symbol that is used for visual acuity testing. Allen cards can be used for preschool children, and they're designed on a 30-foot denominator. They measure the furthest distance that the child can identify 3 of 4 pictures, and scored at the distance over 30. Comparison of one eye to the other is more important than the absolute score of either eye. Describe the advantages and disadvantages of different low vision devices. First, optical aids can be conventional corrective lenses. High-minus lenses can be used for myopes or as part of telescopes. Contact lenses can also be corrective lenses. Magnifying lenses can be used at distance and near. And then there are hand readers. These could include stand magnifiers, telescopes, desktop projection devices, and distance magnifiers. Some examples of non-optical aids include a reading rectangle, large type, yellow filter, and writing guides. We're now on to visual field testing, which is 4% of the COA exam. Perform Amsler grid testing, perform confrontation fields testing, perform automated perimetry, perform Goldman perimetry. The definition of a visual field is the full extent of the area visible to an eye that is fixating straight ahead and is measured in degrees from fixation. Fields from right and left eyes overlap, and the overlapping section is binocular. Visual fields testing, perform Amsler grid testing. The Amsler grid assesses the central 20 degrees of the visual field and is useful in detecting small defects in the macular and perimacular region. It consists of a grid of squares, and the whole grid subtends 20 degrees. 20 by 20 squares measure 5 millimeters each, or 10 centimeters by 10 centimeters. Each smaller square subtends 1 degree at a distance of 28 to 30 centimeters. When testing a patient with the Amsler grid, you should ask 4 specific questions. You should ask the patient, can you see the center spot? While looking at the center spot, can you see all 4 corners? While looking at the center spot, can you see the entire grid? While looking at the center spot, are all the lines straight and parallel? If the patient cannot see the center spot, as the example here, If no, this could indicate a central scotoma. While looking at the center spot, can you see all four corners? If the patient cannot, as in this example, this could indicate an arcuate scotoma. While looking at the center spot, can you see the entire grid? In this example, no, this could indicate a paracentral scotoma. While looking at the center spot, are all the lines straight and parallel? And in this abnormal example, this indicates metamorphopsia. Performing confrontation fields. This test is a gross test of the patient's peripheral vision or visual field. It requires no equipment and can be performed anywhere. Sit around 1 meter from the patient. Examiner and patient should close or cover the same eye. Present a target exactly halfway between you and the patient identifies the target. Test all 4 quadrants of the patient's vision. In this picture, the technician is using her fingers as a target. You would then document your results as shown. Visual confrontation visual fields are documented from the patient's view. And CF is documented in each quadrant. This indicates the test was within normal limits. If the patient was unable to see a quadrant, that area would be shaded. Again, this is from the patient's perspective. This would be an example of a patient's right eye. They were unable to see in the upper right quadrant of their vision, indicating a right upper quadrantanopia. Again, another example of a constricted right visual field, documenting from the patient's perspective. This would be a patient's right eye, and the entire right hemisphere of the right eye, upper and lower, the patient was unable to see the object. This would indicate a right hemianopia. Performing automated perimetry is also part of the exam. Typically, tests are within the central 30 degrees of a patient's field. There are a few screening tests that test out further than 30 degrees. Some examples of automated perimetry are Humphrey and Octopus, as well as others. And these automated machines run very specific programs. Until recently, the automated machines were only able to perform static perimetry, but now Humphrey and Octopus have automated kinetic testing. The island of vision in a sea of darkness is a concept that you could possibly see on your COA exam. The picture over to the right is depicting an island of vision in a sea of darkness. The very peak of the island corresponds with the fovea, and as the outer edges slope, the outer slope corresponds with our visual field. Peripheral vision can be defined as 60 degrees nasally, 90 degrees temporally, 60 superior, and 70 degrees inferior. Goldman perimetry is an example of manual perimetry. It employs the static or stationary and kinetic moving strategies and is able to test further out in the periphery. With Goldman perimetry, one is able to map an isopter. The definition of an isopter is the line connecting points denoting areas of equal sensitivity to light. A scotoma is a non-seeing area within the visual field. Scotomas can be absolute or relative. An absolute scotoma cannot be seen with even the largest and brightest target available. A relative scotoma indicates there's an area in the patient's vision that can only be detected with a small or dim target. Depression indicates an overall reduction of the entire visual field. Pupil assessment is 3% of the COA exam, which includes measure, compare, evaluate, shape of pupils, and RAPD. The pupil is a central hole in the iris and allows for light to enter the eye and hit the retina. The pupil regulates the amount of light that enters the eye by 2 muscles in the iris sphincter and the iris dilator. In measuring pupils, the size of pupil varies with age, color of iris, refractive error, and mental status. A ruler may be used and measured in the center of the pupil and measured in millimeters. A normal pupil size is 3 to 5 millimeters in a lit room. Different size pupils as compared from right eye to left eye is termed anisocoria. The difference must be 1 millimeters or more to be considered anisocoria. Determine if the difference is greater in light or dark to determine if the smaller or larger pupil is abnormal. Evaluate and record pupil function and reaction. Be sure to look at direct response and consensual response. Direct response refers to the constriction upon direct illumination. Consensual response is what happens to the other pupil, the one that is not having light directly shown in it. It should also constrict upon indirect illumination. So in other words, what one pupil does, the other should do as well. So in this picture, you can see that upon direct illumination, the other pupil also constricts. So direct response and then consensual response from the other pupil. Pupils normally should be round and central, sometimes slightly nasal. Examples of abnormal pupils could be a tadpole shape or scallop shaped, and the term polychoria refers to multiple pupils. The RAPD is identified by performing the swinging light test. Normally, each pupil should constrict to direct light and to light directed at the other pupil. That's a consensual response. In a RAPD, there's apparent dilation of the consensual pupil, the affected eye, with direct illumination of the stimulated eye, the non-affected eye. A positive RAPD is a sign of optic nerve disease. Here's an example of an RAPD. And we can see when light is shown in the right eye, the left pupil responds. And the left eye, which is the one with the RAPD, it responds, but it doesn't respond quite as much as the right. As the light swings from right eye to left eye, we can see that upon direct response, the right and left pupils are not the same size, and the other pupil consensually responds to that as well. You can see a dilation from right pupil to left pupil as the light swings back and forth. I'm actually going to play that one more time so you can see constriction of both pupils. And swinging to the left eye now, constriction, but not as much. Then, as the light will swing from right to left eye, you will notice a dilation of the left pupil, indicating an RAPD. So why do we check pupils? Abnormal pupils can identify an optic nerve problem to the doctor, and we must check pupils before dilation. Once a patient's dilated, the opportunity to assess pupil reaction during that visit is lost. Most pupil assessment is done with only a handheld flashlight. Examples of these are a muscle light, a direct ophthalmoscope, and others. The pupil can be assessed with the slit lamp as well. What you're seeing here is an example of hippus, which is a normal rhythmic contraction and dilation of the pupils. Now moving on to tonometry, which is 4% of the COA exam. Measure intraocular pressure with handheld applinator. Measure intraocular pressure by applination tonometry. Measure intraocular pressure with non-contact tonometer, and clean and disinfect tonometers. First is indentation. This method measures the IOP based on the eye's resistance to being indented by a certain weight. The less the indentation, the harder the eye and the higher the IOP. This depends on a patient's scleral rigidity. The Schiot's tonometer is an example of indentation. Some advantages of the Schiot's, and historically it was used because of its low cost, it's very portable, it's reliable, and it's relatively easy to use. It must be done in a supine position, and it does require a conversion chart. Next method for tonometry is applination. Applination tonometer, specifically the Goldman tonometer, measures the IOP by flattening the cornea a specific amount with a prism tip. The end of the prism tip is 3.06 millimeters in diameter, the amount of the cornea that's being flattened or applinated. The higher the force required to exactly flatten the cornea, the size of the prism tip, the higher the IOP. Applination tonometry is not affected by scleral rigidity. In the image to the right, you can see a simulation of applination tonometry and the mires that are seen when looking through the oculars and the biprism makes contact with the cornea. Other methods of applination are the Perkins and the Tonopin. The Perkins is an applination type and uses a prism similar to the Goldman, as seen pictured here on the left. The Tonopin is also an applination type, and it also requires anesthetic and a Tonopin tip. The eye care tonometer uses a very light touch from a probe. No anesthetic is required, and probes are single use. The Goldman tonometer is mounted on a slit lamp. It is an applination type. Pressure is derived from the amount of pressure required to flatten the tonometer tip. remembering that the tip of the biprism is 3.06 millimeters in diameter. A biprism in the tip creates the Myers pictured to the right. The endpoint of Myers is when the inner part of the semicircles are just touching. The image here demonstrates a correct endpoint when using the Goldman method. Symptometry is also non-contact. The applanation type uses air to flatten the cornea, where no part of the tonometer actually touches the eye. This is a good screening tool, but it should be kept in mind that high measurements with non-contact should be confirmed with the Goldman. Be sure to always follow clinical and institute policies, and always disinfect your tonometer tip. Disinfection systems used are an alcohol wipe, where you can wipe clean and disinfect, and wait 30 seconds after wiping to be sure the tonometer tip is dry. 3% hydrogen peroxide, soaking the biprism for 10 minutes, or soaking in a 1 in 10 dilution of liquid bleach. Ethanol or isoprene, 70%. Be aware of potential damage to the tonometer tip, so be sure to inspect it to look for any cracks. Otherwise, it will need to be replaced. Keratometry is 2% of the COA exam, and perform automated keratometry. Keratometry is the measurement of the curvature of the cornea, specifically the anterior cornea, in the central 3 millimeters of it. It's documented in diopters or millimeters of curvature. The first example here is diopters, 43.5 by 44.25 at 87. By convention, you would record the flattest curvature first, as in the example above, where 43.50 or 43.5 is the flattest curve, where 44.25 would be considered the steepest. This is referred to in short as a K reading. Regular astigmatism would be considered axes that are 90 degrees apart, irregular axes that are not 90 degrees apart. A with the rule astigmatism is an optical power that is greater in the vertical meridian, and against the rule is optical power greater in the horizontal meridian. 4% of the exam, ocular motility testing, Pershing's inductions, functions, anomalies, cover tests, stereoacuity, and nystagmus. Ocular motility is defined as movements of the eye in all directions of gaze and to its relationships in movement with its fellow eye. Strabismus is defined as failure of the eyes to simultaneously focus on the same object due to muscle imbalance. Examples of strabismus are tropia and phoria. Atropia is a manifest deviation, meaning it's always there. You can always, a constant eye turn. You can always see it in your patient. Aphoria is a latent deviation, seen only when fusion is disrupted. Direction, manifest deviation, and latent deviation. An in deviation, manifest, is an esotropia, latent esophoria. An out deviation, manifest, is exotropia, latent deviation, exophoria. Up, manifest deviation is hypertropia, latent deviation, hyperphoria, while an eye that's constantly turned down is a hypotropia, or sometimes turned down, hypophoria. There are 6 extraocular muscles, and listed here are the 6 extraocular muscles with their primary action and secondary actions. We can see that the medial and lateral rectus have a primary action only. The medial rectus is an adductor or adductor. Its primary action is abduction. The lateral rectus, its primary action is abduction or abduction. The superior rectus's primary action is to elevate, and secondary actions are intorsion and adduction. The inferior rectus, its primary action is a depressor, and secondary actions are extorsion and adduction. The superior oblique, its primary action is to intort, secondary actions are depression and abduction, and lastly, the inferior oblique, its primary action is extorsion, secondary actions are to elevate and abduct. So let's take a look at versions and ductions. The duction is the movement of a single eye considered independently from the other eye. Its movement is around one or more of the 3 pictured axes on the right: the vertical axis, transverse axis, and sagittal axis. Let's take a look at some pictures of these following movements. So remember, duction is looking at one eye. Adduction or adduction is the eye moving in, as pictured on the top. Abduction, abduction is the eye moving out, as pictured on the bottom. Supraduction would be the eye moving up. Infraduction would be the eye moving down. Let's look at intorsion and extorsion. Intorsion, also called encycloduction, is the 12 o'clock position of the eye moving inward, as seen in the picture above. The picture below demonstrates extorsion or excycloduction, and it's the 12 o'clock position of the eye moving outward. Inversions. This is the observation of the simultaneous movement of the eyes in the same direction. The eyes move parallel around the vertical axis. Dextroversion refers to movement to the right. Levoversion, movement to the left. Superversion, movement up. And introversion, movement down. Going back to our terms tropia and phoria, these are considered anomalies. Atropia is a manifest deviation of the eyes that is constant and readily observable. It's always there. Aphoria is a latent or hidden deviation that is seen only when fusion is broken. Looking at the following example of an anomaly, here is an exodeviation. This deviation is outward. Esodeviation, deviation inward. Hyperdeviation, up, and hypodeviation, down. Cover tests help us to determine if there is a heterotropia or tropia. Cover-uncover tests help us to determine if there is a heterophoria or phoria. The alternate cover test or cross-cover test determines the full deviation to be measured, as it will bring out any phoria that is present in addition to the tropia determined on a single cover test. Let's take a look. Ask the patient to fixate at a distant target. Cover one eye, keep it in place for approximately 1 to 2 seconds, and observe the other eye for any shift in fixation from a deviated position to one that fixes on the target. You would then perform on the other eye. The cover-uncover test asks the patient to fixate again on a distant target. Cover one eye and keep it in place, and attention is turned to the eye that has been occluded as the occluder is pulled away. If the uncovered eye does not show a fixation shift as the occluder is placed, but as the occluder is pulled away, the covered eye shows a refixation movement once binocular conditions are restored. This represents aphoria. The cross-cover test asks the patient to fixate again at a distant target, but this time quickly move from one eye to the other and back without allowing the patient to fuse in between. Disruption of fusion will bring out aphoria if present. The eye under the occluder is observed as the occluder is removed and placed over the fellow eye in order to determine the direction of deviation. Looking at the note under our simulation, exophoria develops if present, and note that the transparent occluder allows you to see what is happening under it. Stereoacuity, depth perception. The ability to judge distances when all clues except binocular triangulation are eliminated. Depth perception requires 2 eyes, good vision in both eyes, and that each eye views an object from slightly different angles. The brain fuses the slightly disparate images from each eye to create stereoscopic image. Nystagmus is characterized by involuntary rhythmic to and fro oscillations of one or both eyes. Most commonly, nystagmus is horizontal. However, it can be vertical, oblique, or rotary. Patients will often adopt a head posture to correspond to the eye position where there's least amount of movement. Nystagmus can also diminish visual acuity. Lensometry is 3% of the COA exam. Neutralizing spectacles, automated and manual. Lensometry defined is the neutralization of spectacles. It is used to determine the prescription of a pair of glasses. It can determine sphere, cylinder, axis, reading ad, and prism. In a spherocylindrical prism, the example plus 250 plus 1 at 95 determines that the sphere is plus 250, a cylinder of plus 1 with an axis of 95 degrees. There are various makes and models of automated lensometers. Lens analyzers neutralize a lens with a push of a button and digitally outputs the glasses prescription. There are different display options. You can pick plus or minus cylinder and variable round-off modes. Measure all components of the spectacle prescription. Lens analyzers are capable of this, where they can measure sphere, cylinder, axis, and add power, as well as prism. Manual lensometry, there are a few steps. You turn the power on and focus the eyepiece first by rotating the eyepiece all the way counterclockwise until the mires are blurry, and then rotate clockwise until the reticle is sharp. So rotate counterclockwise until the Myers are blurry, and then clockwise until the reticles are sharp and in focus, as pictured above. Next, you'll position the spectacles on the stage and use the stage adjustment lever to either move the spectacles up or down or side to side. And you want to be sure that the Myers are centered in the very center reticle. You will next align the axis, and in the box, you can see, the red box, you can see 3 broken slants. This is indicating that our lens is off axis. Look through the eyepiece and rotate the axis wheel, and you'll continue to do that until the broken pieces are aligned. Once they are aligned, you have achieved an on-axis lens. You will focus the single lines and record this as the sphere. Rotate the power drum until the single line set of Myers come into sharp focus, as pictured. Focus the triple lines. This helps to record the cylinder power. You're going to record the distance traveled as the cylinder. Rotate the power drum dial towards you for plus cylinder until the triple line set of Myers come into sharp focus. It's the distance traveled from your sphere reading to your cylinder reading to record your cylinder power. You would then record the axis directly off the axis wheel. Reposition the glasses on the bifocal and refocus the single line. The difference is the add power. So looking at our example on the right, from our first reading to our second reading, our first reading of plus 75, our second reading of plus 2 with our bifocal positioned in place, the distance traveled is plus 125.